All right, welcome everyone. I'm Elias. I'm the chair for the critical care medicine section. Today we'll start our August section meeting with a paper, the PACER trial. So it's platelet transfusion before central line placement in patients with thrombocytopenia. Um, so this study is interesting. It's not a retrospective trial. It's actually a randomized open label non-inferiority trial, single blind. It was done in, I think, New Zealand or some European country. Um, but it was a multi-center trial. The goal was to set as non-inferiority, so they wanted to compare transfusion with non-transfusion, and they wanted to see a 2.5% increase in absolute risk for uh, grade 2 to 4 and bleeding. And the grade 2 to 4, meaning 2 minor intervention with compressions more than 20 minutes. 3 would be bleeding with radiological or elective interventions, a red cell transfusion, and 4 would be a hemodynamic instability that required more serious intervention, resuscitation, or even death. So they wanted to compare that as the main primary outcome. Other things they looked at for the secondary outcome was any other signs of bleeding, hematoma sizes, ICU length of stay, those kind of things. So it's the Netherlands hospitals, 7 academic, 3 general hospitals. They had 180 around for each group for the transfusion, non-transfusion. And the interesting thing was that they included hematology patients and ICU patients. The ICU patients were recruited. Um, they put them in the study initially, and then if they had consent afterward, they would include them in the study, or if they died, they would include them in the study. And hematology patients, they got consent ahead of time. So the interesting finding for the study was that they did find that the transfusion versus the non-transfusion group had some difference. The absolute risk reduction was 7.1 and the relative risk was 2.45, but it didn't meet their criteria to cross over non-inferiority. Um, of course, some things that you would expect is that the platelet transfusion group had a higher platelet on average. They did have a little bit longer median length of stay, but not significant. And most of the others were pretty similar in terms of other regards. So their conclusion was that in severe thrombocytopenia, especially in hematology patients, they probably would recommend transfusion, but in ICU patients, otherwise, they weren't quite so sure. So I don't know. What do you guys think of it? Do you guys routinely look at the degree of platelets before you guys do any lines, or?
Yeah, I think this was an interesting paper because I have to say this was probably, I don't know if this was just my shop as a resident, pretty fairly
Mm,
routine practice. I think the number was always debated. But I have to say somebody with high level bleeding, high INR, dialysis, or even liver patient, um, in an ideal world, we would transfuse platelets right before line. I have to say the practicality of that, because you know how it goes, like you try to wait, there's a platelets. I think this only applies to centers that are probably in the mothership, the platelets are already available, because certainly you're
yeah.
not going to wait 6 hours to put in a central line if they need it. Um, but I think I was doing this before, and I think this definitely gives evidence to continue the practice if it's available, not harmful, high risk of bleeding, consider doing the unit before. Um, I think an interesting question that I take home for this, and similar with the device trial, as far as a
Hmm.
medical education trainee standpoint, is again, this was an ideal. They tried to find senior providers putting in the CVCs. How do we balance trainees doing high risk central lines? Because again, I think the hard part always balancing is you always want the most senior person to do it the first time, but how do you train juniors to become those more senior people if they're never actually doing the complicated procedures?
Right. So it was mandatory that all the providers ultrasound use and had more than 50 lines done. Whether you want to count that as actually expert enough, that's debatable. But um, it is a more specialized in terms of like maybe the complication rates aren't as obvious because of that. So if you include everyone, would that be a different result? What do you do, Greg? Do you do anything different for your shop?
Yeah, it's interesting is that we don't typically give platelets prior to doing percutaneous lines. Obviously, if it's like a cut down or anything that's like a non-Sellinger technique procedure, we'll give platelets for. And our threshold usually is 10 to 20,000. But
Hmm.
it's funny. My group looked at this paper, and this actually gave us a lot of pause, saying that maybe we should actually be giving more platelets. That we might have less bleeding risk. The one of the interesting things I thought from this paper was this. We talked about this in the group was use of composite outcomes
Yeah,
because when you compare grade 2 versus grade 4 and the in between grade 3 bleeding, there's a big difference, right? The
right.
difference between standing there just holding pressure for 20 minutes versus a life-threatening bleed, that's a fairly large margin. And if you look at the subgroup analyses, it looks like most of the difference was driven by the fact that there was there was more type 2 bleeding there. The more of this kind of, you got to hold pressure for more than 20 minutes, which is inconvenient, but not the end of the world.
Right. I mean, it's reassuring in regards to looking at that is that there's no big major bleed regardless of
Yeah.
what you do. But yeah, holding 20 minutes, and could it be like the patient population difference because they also had a trend towards more hematology patients
Mhm.
versus like the low platelets in ICU patients maybe it comes down to pathology, but it wasn't probably a mechanicalistic issue, so their platelets was still functional. So maybe the type of patients really matters.
Yeah.
So
Yeah. So I was taking a similar approach in the last month as Fred is if there are platelets on hand and the patient's gonna get platelets anyway, then I'm gonna wait until the patient gets platelets before I put the line in. If it's like truly emergent, then you do what you gotta do in the moment and you deal with the consequences afterwards.
right. Ali, Kane, are you guys here? Do you guys have do anything different on your shop?
I usually, in general, just kind of as a new attending or fresh out of practice and kind of just
Hmm.
nervous, I tend to do the more conservative thing. And so, like, working at a level 1 trauma center, we usually have platelets. And so, like, if their platelets are less than 50, I'm usually going to go ahead and get the platelets. It shouldn't take too long. It obviously affects like where the line goes. I do think 50 is an interesting number because when you look at a lot of different hospital credentialing things across physicians or even across like APPs, like a lot of different centers use like a threshold of like around 5 or 15 central lines. And so like,
Yeah,
and like, I do think that like 50 is probably like a good, like that you've done several central lines by that point in time. And hopefully that you are pretty competent, but of course an absolute number or numbers as you
right.
alluded to is not you can't determine.
That's always debatable. I mean, I've done a lot of lines, but I know at some point you're getting a mastery, but I don't know what the cutoff is exactly. Everyone's a little bit different too.
Yeah, everyone's different, and it's kind of like, well, we all could spend a million hours driving a car, but most of us, despite driving a million hours, we're not going to be at the level of a NASCAR driver. It's kind of like how you utilize that time too, I guess.
Yeah,
and
so
like and like your attention to detail as you're watching other people doing the procedure, because like at some institutions, like there are a lot of different trainees who might kind of get it, like skirt around it, and they might not pay attention as much, and they might just count being in the room or count like being involved for a little bit of the procedure as part of a line. So it's kind of like how you depend or how you utilize your time and like and how you're engaged in a procedure too.
all right. How about you, Kane? Anything different you do in your shop?
No, I think this paper kind of may change some things because typically, we were maybe giving platelets for people that were less than 20,000 that had like a
Okay.
severe risk of
Yeah,
bleeding, depending on other comorbidities, if they're cirrhotic and then other coagulopathy and things like that. So we were probably not as liberal with giving platelets up to this 50,000 mark. And now with this data, even though it's a single center trial, um, people are kind of using this as, hey, maybe we should give platelets for this person who is below 50,000 because we'd have less bleeding risk. So I think this is good start to the evidence base. Maybe we need, of course, a larger trial, more differentiation between 20,000 to 50,000 in increments, and see like what the bleeding risk was really with a larger trial. But I think this is a good start, and I don't think there's any harm necessarily of giving 1 unit of platelets like they were doing in this particular study for people that are less than 50,000.
Yeah.
Definitely if they have a high risk of bleeding and other coagulopathy or other medical problems that would exacerbate bleeding or cause more bleeding. I don't think this is a bad thing. I think one of the things that they don't mention is, or necessarily don't get into in much as platelet dysfunction. So some of these people who may be less than 50,000 may have some type of other issues for platelet dysfunction, and they may need some additional medications for the platelet dysfunction or reversal for the platelet dysfunction. So
I
that
think
might
they
help as well
did
too.
exclude some people with some baseline hematological issues, or I think they changed their INR criteria. It was like 1.5, and then they changed it to 3 because it wasn't as strict as a cutoff. So they made some changes with that. But yeah, those are different kind of populations. And like I said, the hematology, ICU patients, maybe different types of patients. I don't know if they mentioned cirrhotic specifically. That might be a whole different type of patients that, if we look at it, might be a different cutoff. Yeah, it's interesting. Although they did do different lines and different positions, so that was also interesting that there wasn't any difference between those things. Because sometimes you would think that doing a bigger line like a dialysis line would cause more bleeding, but not necessarily this study. Aaron, Caitlin, since you guys are kind of still doing training kind of things, do you guys have any take on this, or what do you guys think?
I haven't seen platelets given frequently, especially down, especially before procedures, but I think that's more of the nature of these lines are emergent and then.
Would this change your practice? Like if you had a patient that you might think that they have a lower platelet, or you so happen to get it earlier, would you consider giving them platelets if you're doing an emergent procedure then?
I think if it's below 50, I'll think about it. 20, I would try, but we don't necessarily have platelets move up that quickly from the blood bank.
I completely agree. I'm kind of at the point in my training where my opinion or desire to give platelets or not, or at what level, really doesn't matter. It's really what the attending or residents are feeling. And a lot of this, like more recent literature and stuff like that, hasn't really disseminated widely yet. So and then there's also the time limit thing in the emergency department. People just, unless there's a major benefit, I don't think they're really focused on this, unfortunately.
Right. I mean, in this study, it wasn't absolutely positive, so technically there's no difference if you want to argue. So technically you could say that you don't need to. But I mean, it probably just depends on practice. Like for me, in the CTICU, it probably depends on the surgeon's preference a lot more. I'm pretty comfortable doing a line even with a low platelet because I know my procedure is probably not going to cause significant bleeding because I can get in and out as quick as possible, but you never know. In a lot of patients, sometimes you still have that risk. And I've seen it before, like even though I'm comfortable with procedures, some lines end up being more kind of more bleeding than other lines. And I'm sure the other attendings can tell you never can predict until you actually do the line.
So would the experience of the provider doing it have any effect on whether you give platelets or not?
That's what we were talking about with Fred's comment earlier, is that if it was like even an intern or someone who's never done a line before you're doing it, would you want to give a platelet if someone's between like 20,000 to 50,000? That's actually a debatable thing, and that might be an interesting study to look at. Unfortunately, this study is geared, like Ali's saying, most of the criteria to meet proficiency is 5 to 15 in most institutions. So getting to 50 is usually, you can count it as usually quite proficient. So that is debatable. So if they want to look at someone across the board without any expertise and requirements of doing lines, that might be something they look at in the future. How about Greg and Kane? Would you allow someone to do a line who has only done 1 or 2 lines and their platelet is like 20,000? Would you give them a platelet instead?
I'd probably give platelets for that particular situation. I think kind of like you alluded to, having done a lot of lines and just your level of experience, depending on the situation, I may not transfuse the platelets for if I was doing the line or if somebody is more experienced. But certainly maybe somebody who's less experienced, I don't see any harm in doing that. It'll probably be needed at some point anyway.
Yeah, I take a similar approach. That I still might give them a chance, or sometimes what I'll also do is I'll be gowned up there with them, and honestly, where I think a lot of the bleeding happens is when you have multiple sticks, is when you are trying to get that needle into the vein multiple times. I have certainly, for very junior learners, put the wire in for them, and then say, "All right, here's the wire. Show me what you're going to do next." Because at that point, the bleeding risk is now largely mitigated. I guess if they shove the whole dilator in, then then they're going to bleed again. But that's also something there. It's just trying to judge what the learner is at, because I'm always loath to take away a procedure from a learner, because this is their chance to learn, and under ideal circumstances we would have an infinite number of low risk patients, but the reality is we don't. I feel like this is like the lesson during COVID is, for a while we didn't let any of the learners intubate during COVID, then we recognized that's frankly all they're going to get. So they're going to learn how to intubate COVID. One other thing I wanted to bring up with this paper too, and just it's just interesting, because in my institution, the platelets that we use are mostly apheresed, unmatched, non-ABO matched platelets. Most of it's just type A platelets. So if you call for unit platelets at my hospital, you'll get a unit type A, typically. This institution used non-matched pooled platelets, which is a little bit of a different product. That's not something we typically use in the United States. In theory, you should have a little bit more of a platelet response. But I'm curious, are other people using unmatched pooled platelets? Or are they using matched apheresis platelets? Does anyone know?
I don't think anyone really knows, I
Okay.
guess. But it could be, well, that is another thing. This is a different country technically, so whatever they use, the products they use, there might be some different in protocol wise. So whether that translates towards here might be a different story.
And a good portion of the units from the patients were all hematology units. So I wonder here, like that would probably end up being like the apheresed or radiated, all typed, that I think probably would be a different response. Although the interesting part is it showed you like pretty consistent response, that I think the intervention group went up to about 46 or 50, and then both groups were back to 26 once the half-life was over. I think the interesting part with all these intervention studies too to think about is that kind of intervention bias or Hawthorne effect, that I think it was hard to blind everybody. So the same thing with you probably do routinely when it's a difficult line, you probably double check, go a little bit slower. So I wonder if there's just less complications because you're moving at a less high speed than you normally would, or if you knew you were in this study, you just took it a little slower, and probably dilated a little bit less and stuck a little bit slower. And I wonder how much that skewed the numbers too.
Yeah, that's always something that's debatable, but it's not something that we can actually do, because you can't exactly blind everyone. At least they try, because most of the providers actually don't know if they are getting platelets or not, or at least they try to do it. So majority-wise, I think they attempted. But it's hard to achieve that perfect double blinded kind of scenario. So I guess this study is not like a groundbreaking kind of practice changing, but does make us pause to think about in the 20 to 50K kind of region, whether we need to be more cautious or consider giving platelets, especially if maybe as learners are involved. That's something that some of the attendings might be thinking about looking at this paper. But it might need more studies going on. So we'll have to see. All right. Any other people have any more comments or? Nope. All right. I guess that runs it, Elizabeth. So we're good.